Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Occult Metastases in Lymph Nodes Predict Survival in Resectable Non-Small Cell Lung Cancer. Report of the ACOSOG Z0040 trial by Valerie Rusch et al. My name is Kemp Kernstein, and I am Professor and Chairman of Thoracic Surgery at the University of Texas Southwestern in Dallas, Texas, United States of America. My oncology specialty is thoracic surgery. I would like to disclose that I contributed patients to the study that is the subject of this podcast. Solving the mystery of recurrence in surgical cures for early non-small cell lung cancer. It is well known that lung cancer has a poor survival. Although early stage disease is primarily treated with curative intent, 30 to 40% of stage 1 patients will recur and die of their disease within 5 to 10 years. There have been different strategies to identify those lung cancer patients who are more likely to recur. Evaluation of the primary tumor by assessing the genome, such as with DNA sequencing, DNA profiling, or genotyping. Assessing the transcriptome, or mRNA, or assessing the proteome, all to better determine the biological nature of the malignancy. Another strategy is to directly pathologically evaluate for occult metastases, as was performed by the American College of Surgeons Oncology Group, or ACOSOG. The study by Rusch et al. Is the largest multi-institutional prospective trial ever performed to assess for lung cancer occult metastatic disease, and because of the relatively recent introduction of adjuvant therapy for early-stage lung cancer, this study will likely never be repeated because many of these patients would be receiving adjuvant therapy. The goal of the investigators was to identify a group of lung cancer surgery candidates with stage 1 to stage 3B disease who were to undergo standard surgical resection, then to assess for occult disease in 3 locations: resected lymph node, saline pleural wash or lavage at the time of resection, and resected rib bone marrow. The primary objective was to evaluate the relationship of identified occult metastases with long-term survival. A total of 1,310 patients were accrued from July 1999 to March 2004. 263 of the patients were considered ineligible, approximately 20% of the total. 114 were lost to follow-up, and thus there were 933 patients, or 78%, considered eligible for evaluation. There was a double registration after the CT scan, and then at the time of thoracotomy to confirm operability and the presence of lung cancer. A 3 to 4 centimeter segment of rib was resected at the time of thoracotomy, and then there was a 250 milliliter saline pleural wash that was performed before and after the resection, aliquots of which were sent for analysis. There was no mandate as to the type of surgical resection, and thus approximately 10% of patients underwent a sublobar resection. There was also no mandate as to the means at which lymph nodes were resected, either by sampling or by complete lymphadenectomy. All lymph nodes were assessed by the home institution. There was a standardized follow-up plan for 5 years after the resection. A broad battery immunohistochemistry was performed on both bone marrow, and histologically negative lymph nodes using anti-cytokeratin antibodies CAM 5.2 and AE-1. Two blinded pathologists assessed the IHC slides, and if there was a discrepancy, a third was brought in to settle the difference. The patient demographics were similar to most recently published groups in the literature. The average age was 67 years, with a slightly fewer percentage of men and a paucity of minorities. Approximately 80% underwent lobectomies, and 95% of the patients had an R0 resection. 50% of the patients had an adenocarcinoma, and 66% of the patients were stage 1. 29 or 3.3% of patients had a pre-resection positive lavage, and 17 or 2% had a positive post-resection pleural lavage. The bone marrow was positive in 66 or 8%. For those patients that had a negative H&E lymph node evaluation, 130 or 22.4% were found to be positive on immunohistochemistry. 10 patients, or 2.2%, had occult metastases in the bone marrow and lymph node combined. Occult metastases in the bone marrow did not appear to worsen the prognosis. However, occult metastases in the lymph nodes reduced the disease-free and overall survival with a hazard ratio of 1.63 and 1.59 respectively. There did not appear to be a correlation between the number of IHC-positive lymph nodes or the number of lymph node stations that were involved and survival. In a subset analysis, the greatest survival difference was found in stage 1B with a hazard ratio of 1.82, and no difference was seen in stage 1A patients. The authors evaluated the effect of the two different staging systems, UICC6 and UICC7, and found similar effects. In their discussion, the authors commented on their reduced percentage of patients that had cytologically positive pleural lavages, 3%, rather than a recent meta-analysis finding of nearly 6% that had a positive lavage. Also, in contrast to the meta-analysis finding, the authors found no increased likelihood of recurrence or death from the malignancy. The authors claimed that their lavage technique was standardized and more likely to demonstrate biologically relevant disease. They found that 8% of patients had occult disease in the bone marrow, half of many published reports, and it too did not correlate with survival. On the other hand, the 22% of patients that had occult disease in histologically negative nodes was found to portend a poorer prognosis and a poor disease-free survival, a poor overall survival, a direction we should more aggressively pursue. In review of this manuscript, it should be kept in mind that there was no standardized means of lymphadenectomy, or staging of the mediastinum, or a standardized means in which the pathologist at each institution assessed the specimens. Recent studies have found that there is significant variability in all of these features across institutions. Large, well-performed population studies have demonstrated that the evaluation of at least 10 to 16 lymph nodes and assessing 3 to 4 different lymph node stations appear necessary to assign the appropriate pathological stage. Furthermore, positron emission tomography and PET-CT have demonstrated a more thorough assessment for metastatic disease and were not included in this trial as they were not consistently available during the enrollment. Additionally, molecular biomarkers were not assessed either, information that might have been helpful to assess for biological behavior and recurrence, potentially more important than immunohistochemistry assessment of resected lymph nodes. However, given all of these deficiencies, this paper demonstrates that there is a group of early disease, surgically resected patients with immunohistochemistry proven lymphatic disease who are more likely to recur. Perhaps these are the patients that are more likely to obtain the greatest benefit from adjuvant therapy, although this will require prospective evaluation in future clinical trials. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.